Hello, everybody, and thank you very much, Dr. To the MitraClip procedure. These are my disclosures. I get research grants from St. Jude Circulite. Mitral regurgitation, as it occurs, is usually due to malcoaptation of leaflets. MR occurs as a result of dilatation of the ventricle or annular dilatation or papillary muscular dysfunction. And this group continues to rise because of from coronary congestive heart failure. Here's an example of a patient with the annulus which is dilated, the leaflets are restricted, and there's severe mitral regurgitation. Now, the treatment options for severe MR is usually surgery. And the options are repair or replacement, and mitral valve repair is the preferred treatment choice. That you pay with, and that is mortality and morbidity, which ranges between 1.5 to 5%, and sometimes much higher in high-risk group of patients. And therefore, there is a need for something less invasive and safer. Interventionist cardiologists, as you know, are natural predators, and they always try to find a way and try to copy what surgeon colleagues do. So here's an example of their principle that anything that cardiac surgeons can do open, we can try to do them percutaneously. So here's an instance where we've taken the different types of surgical approaches and adapted them. And one such important technology is the leaflet repair using the MitraClip. The MitraClip is actually developed by a company called eValve, and later this company was bought by Abbott Vascular, so MitraClip is now owned by Abbott Vascular. So the principle of the MitraClip procedure is this edge-to-edge repair. This operation was described by Dr. Alfieri in Italy, where he described a simple operation where you can see over here a prolapsed anterior leaflet, which was attached by two sutures to the posterior leaflet, where he converted an incompetent prolapsed leaflet valve into a competent double orifice valve. This relatively simple and yet elegant procedure has been adapted into a percutaneous technology, and that is what I'm going to talk about, and that is the MitraClip device. So the components of the system is a guiding catheter, which is a 22 French guiding catheter, and then you have this clip delivery system, which lies over a stabilizer. The guiding catheter is about 22 French and it's about steerable, and the clip delivery system has multiple knobs, at the end of which you have the MitraClip. And this is the magnified view of MitraClip, and you can show you the two ventricular arms. They're about 8 millimeters long and 4 meters wide, and they're these atrial grippers. And the beauty of this procedure is that the clip can be opened and closed with the help of the pulleys. And you can see over here, the clip is opened, the ventricular arms are further opened, and then they see over here, we are removing back the atrial grippers. The leaflets drop into the ventricular arms, the grippers are pushed down, the leaflets are grasped, and then you close the clip. And the beauty of this procedure is that if you don't like it, you can actually remove the whole thing by actually inverting the clip and putting the atrial grippers back. The procedure is done in the cath lab with general anesthesia. You need anesthesiologists, echocardiographers, and interventionists. It is important to first confirm that there's severe mitral regurgitation, where the valve is leaking from the middle of the valve. Then we proceed to do the transseptal from the transfemoral venous route using the standard Brockenbrough technique. After we get access into the left atrium, we advance the 22 French guiding catheter into the left atrium. It's very important to make sure that our transseptal puncture is about 4 centimeters above the plane of the valve. The clip delivery system is then advanced into the left atrium, and once it's in the middle, with the help of the pulleys, the clip delivery system can be steered towards the middle of the valve. And this is very precise, and this can be done under echo with multiple views. And once we're right over the middle of the valve, the clip delivery system is kept stable and the clip is opened. And the clip is open, and we make sure that the arms of the clip are exactly perpendicular to the line of coaptation of the leaflets. And you can see over here, we're trying to align it. We're making sure that it's right over the jet. And with the clip arms open, we advance the clip into the ventricle on a beating heart. And thereafter, it's basically like fly fishing. You just pull up the clip, let the leaflets drop on the clip, and then put the grippers down and close the clip. If the MR reduction is not adequate, you can open the clip and then reposition it and then try it in a different spot. And then over here, you can see an example where we grasp the leaflets, the MR is almost gone, and you can see there's a firm attachment of both the leaflets. You can take your time here and actually make sure that the leaflets are properly attached. And once you've achieved that, the clip is actually deployed at this position. The unique features of this procedure is that the device is repositioned and removable. The procedure is done on a beating heart, and it leads to a better vertical coaptation of the leaflets. All cases, of course, cannot be done by this procedure, as explained. It is important to emphasize it's not effective in rheumatic MR. So it has to be non-rheumatic MR, where the leakage is originating from the central two-thirds of the valve. The etiology can be either degenerative or functional, and there has to be sufficient leaflet tissue to be grasped by the clip. And the protocol exclusions important are that if you have a prolapse valve, the flail gap should not be greater than 10 millimeters, and the flail width should not be greater than 15 millimeters, and the coaptation length should be less than 2 millimeters. It's also important to make sure that the mitral valve area is greater than 4 square centimeters. The setup, as you can see, is pretty relaxed. Over here, the anesthesiologist puts the patient to sleep and falls asleep. The echocardiographer stands behind the table, and you can see over here, a fellow is being assisted by a PA in doing the procedure, and I'm standing way behind just reading my emails or just controlling it from a distance. Imaging is essential for the procedure, and this is the use of 3D echocardiography. You can see over here the clip is slightly disoriented. We orient the clip by turning it and making sure that it's exactly perpendicular to the line of coaptation of the leaflets. And then over here you can see by 3D echo we've grasped the leaflets and we've created a double orifice valve. A vascular closure is important. We actually put a 22 French guiding catheter in the vein. We pull it out and apply 2 ProGlides, and we actually can close this venous access site very effectively. We use the right radial artery for the left heart study, so usually the patients can sit up after 5 hours and they usually go home the next morning. This is an example of a 57-year-old lady from Beverly Hills with bileaflet prolapse. She was one of my earliest patients done many years ago. And she came in and she got randomized to the clip arm. And you can see over here the LV angiogram demonstrates severe mitral regurgitation. And we had to put 2 clips, and you can see at the end of the procedure with 2 clips, there's hardly any mitral regurgitation. For the next view, we can show you the echocardiogram at baseline shows that it is severe left MR. And then post-procedure over here, after 3 years, you can see there's only trace mitral regurgitation. Now, I want to emphasize that we don't always get such perfect results, but I just want to show you an example where if you appropriately select the patient and you apply 2 clips, you can really get a reduction of MR. So let's talk about the world clinical experience of this procedure. The clinical experience basically consists of the Everest trial in North America, the Realism, which is a continuous access in the US, and then finally the commercially available European experience. And the total collective experience is now exceeding 2,000 patients. If you took the first part of the Everest 1 non-randomized as the Everest 2 pre-randomized rolling patients that are 105, this is the first experience. And you can see here, even in this very early experience, the survival was about 90% at 3 years, and freedom from surgery was 76.3% at 3 years. What is more important is what actually happened to these patients who had a failed procedure. And those patients who had a failed procedure, either early or late, 67% of them actually underwent a surgical repair. In fact, 88% of them actually underwent the operation that the surgeon intended to do, telling you that the surgical options are preserved in cases where it doesn't really work. The second part of the study was the Everest 2 high-risk registry, and this composed of 78 patients who were extremely high risk for operation, surgery. They had to have an estimated mortality over 12%. And this is what the data demonstrates. And over here, you can see the actual predicted mortality in this group was 18.2%, but the actual mortality in this group was only 7.7% after the procedure, telling you this is a very safe procedure in this high-risk group. In addition to that safety, we can show you the efficacy in this group, and you can see over here that 80% of people had a reduction of MR to 2+ or less at 30 days, which sustained up to 12 months. In addition to these findings, we can show you there's evidence of reverse LV remodeling. The ventricle diastolic diameters and the volumes have reduced significantly over time. The next part, of course, has been the pivotal study, which is the only or the first randomized study of a percutaneous approach versus surgery in a 2-to-1 fashion. And here's the study design, which shows you about 279 patients randomized to device group, which is the MitraClip, 184 patients, 95 to surgery. All of these patients had to be pre-qualified by the core lab, and all of these patients have been followed systematically, echo as well as clinical, for 5 years. The first part is to demonstrate that it's safer than surgery, and you can see over here, if you took the major adverse events in the surgical group, which is in red, it was 47.9%, whereas the device group was only 15%. If you break up these different adverse event points, you can see that one of the reasons which drove the difference was the need for blood transfusions in the surgical arm. If you look at other events like death and major stroke, there were 2 patients who had a death and stroke in the device group. But if you analyze what actually happened, one person actually had a stroke before he got treated. He actually had a stroke after randomization before he even got treated. The second patient had a stroke after he had a failed clip procedure, went for mitral valve surgery, at 25 days had a stroke, and then died. So what I'm trying to tell you is that the complications with the procedure are very small, and all the major events that took place were those who actually had to have surgery. So the next set of slides are going to show you the 12-month effectiveness of this procedure in this randomized study. And you can see over here that we've broken up the data into 2 groups, intention to treat and per protocol. Per protocol means only those patients who actually had a successful procedure, and to see what actually happened to them. If you look at the right-hand screen, you can see over there that in the device group, the effectiveness was 66% at 1 year versus the control group, which was about 74%, telling you that the surgical group was doing better at 1 year. If you look at the major components of effectiveness, which was death, requirement for mitral valve surgery, or MR greater than 2, you can see the death was slightly higher in the control group, and the MR greater than 2 was the difference which caused the difference in the categories, where 16.4 versus 2%. So it tells you that in the surgical arm, you had a better reduction of MR, whereas in the device group, you had a slightly less effective reduction of MR. The 2-year results are quite interesting, and it shows you that this is just the preliminary data, that even up to 2 years, there's actually a sustained benefit, and you can see the device group shows a flat curve, demonstrating that there will be no deaths long term. And we are following these groups of patients for the next 5 years. The other group I'm going to talk about is functional MR. This is a group of patients which are very interesting because they are associated with LV dysfunction. They're often high risk for surgery. The surgery leads to a clinical benefit, but then there's a recurrence rate with surgery, and there's actually no improvement of survival with open heart surgery. So there's something less invasive that is required in this group. And if I looked at the data from the realism and the European experience, which is about 1,500 patients, I found out that the demographics shows you that the 60% of these groups were actually had functional MR, and most of these patients were high-risk surgical patients. But the success rate has still been 90%, and there's been a low complication rate even in this category, and there's an increased use of double clips. So putting it into summary, there are over 900 patients with functional MR treated with the MitraClip. The success rate is very high, the complication rate is low, and the MitraClip has led to favorable LV remodeling as well as reduction of congestive heart failure symptoms. This is our own experience of about 108 patients in the last few years. We've had a success of 96 out of 108 patients, which constitutes about 93%. There's been no in-hospital mortality. There's been 2 patients who died at 30 days, there's 3 patients who actually had minor strokes from atrial fibrillation, and all of them recovered. There was been 2 cases where there was partial clip detachment. In fact, complete clip embolization is extremely rare. And in both these cases, they underwent elective repair. Surgery for recurrent MR was about 8 cases, and they all did quite well. And there was only 2 patients requiring blood transfusions. So we can conclude by saying that the MitraClip therapy is a safe option for selected patients with significant MR, an emphasis on the word selected. There's evidence of durability at 2 years. It is less effective than surgery, but potentially safer than surgery in all groups. And the surgical options seem to be preserved. And the limitations, of course, of the study are still small numbers, and it's still an early experience. Will transcatheter mitral valve repair replace mitral valve surgery? Probably not, but there are certain categories which will benefit from it. And what we can say is probably the high-risk surgical patients with a suitable anatomy, functional MR, both low risk and high risk if the anatomy is suitable, and selected low-risk degenerative MR patients where the goal can be achieved to reduce MR to 1+ or less. And here's an example of our situation in Cedars-Sinai, where you can see our chief of cardiac surgery has actually come down to the cath lab, and he wants to learn the procedure with us, telling you that he has realized the importance of this less invasive procedure. In 1 month, this is a picture of this iconic woman who would have probably not been able to tolerate an open heart surgery with her comorbidities, and she actually went home 1 day after a procedure. I finally want to make some acknowledgements. The Everest investigators, the Abbott Vascular team, the research coordinators, and perhaps most important, the patients who had the courage to be in this study. And thank you very much.
I'm told Saibal Kar is available on telephone, so 1 or 2 questions. He won't be seen, but he will answer. Are there any questions? Just time for 1 or 2 questions. Yeah. Sunil?
The patients with functional MR with very low ejection fractions, like something like cardiomyopathy with severe MR.
Yeah. Can you hear the question directly, or shall I have to repeat? Or
I think you need to repeat.
Saibal? Hello? Dr. Saibal Kar? Hello? It's California, so the earthquake area, that can't hear much. Thank you very much.
Hello?
Oh, Saibal?
Yes?
This is Dr. Ashwin Mehta.
Oh, Ashwin, how are you?
Good,
How
good.
are you doing?
That was a very elegant presentation. There is a question for you.
Yes.
If the patient has a mitral regurgitation with a suitability of a clip, but his ejection fraction is very low, like as in cardiomyopathy, what would be the outcome, and would you accept such patient?
Yes. This is an excellent question. Actually, the best indication for MitraClip procedure is people with very low ejection fraction, because the surgical alternatives is very bad. In fact, we've actually had very good results with patients with end-stage heart failure, with severe MR, non-responders to CRT therapy. So this is an indication. This is one of the few definite indications of the MitraClip procedure if he's a suitable candidate. So we have done patients with ejection fraction as low as 15 to 20%. But when it's very, very bad, then we would leave it alone. With less than 20%, we probably won't do it.
Thank you. Saibal, I think it was a very interesting presentation, and there is an audience of about 400 strong here, and they all want to express their gratitude and compliments to you. Thank you very much, Saibal.
No, Dr. Ben, I'm sorry I couldn't be there in person, but I would love to have been there. But, thank you.
Thank you. So now we conclude this very interesting session that we had, and we've got another interesting session coming up, live cases by Marie-Claude Maurice and Rosli Mohammed. And could I request the chairpersons for that session to come? They are, and we conclude this session and we go, of course. And before we conclude, I'd just like to announce the chairpersons of the next session. They are V. Gupta, S. Rathore, Ramanan Chawla, and the expert panelists. Could I ask you all to come to the panel and take your seats? P.P. Mohanan, D. Desai, R. Rajani, M. Vishwanath, and J.L. Sharma. Thank you.
Hello.
You listening? Yes,
So
yes.
we go on to the first live of this morning. Dr. Makle, can you hear us?
Yeah, I can hear you. Good morning to all of you.
Dr. Makle, this is Vivek Gupta from
Are you
the...
able to hear me clearly? Hi.
And we have the other chairpersons
morning,
and the
Dr.
expert
Vivek.
panels here, ready to understand
Yes.
the case.
Yes. Yeah. Okay. Okay. Good morning to all of you, and good morning to all of you, and I hope you had a last night good sleep. Dr. Marie-Claude Maurice and me, we are going to do this sketch today. This is a gentleman who is 63-year-old, and he had, in fact, 2 years back, inferior wall. He has got exertional angina. He is an ex-smoker, and can you show the first run of the angio? From here itself you can show. Can you see the angio there, Dr. Vivek?
Yeah, we can see it very well, but the sound quality is little low. Can you little be louder so that we can understand better? The quality of this, the picture is perfect.
Okay. The sound needs to be adjusted.
Now it's better, yeah.
So this is a left main bifurcation. And now over to Dr. Mari. What will be your strategy today?
So the strategy, we discussed about rotablator, but I think it's not too calcified. So let's say, of course, we will put 2 eyes for sure to secure both branches. Second, we will pre-dilate with a non-compliant trio balloon at the site of the bifurcation. Then stand from left main to the LED with a 3.5 20 stand by a sensor, and then open the circ, make a kiss, and see if there is a need of a second stand. So it will be provisional stenting.
Dr. Makle, can we, in the interest of the audience, can we discuss a little more of the clinical part of the case? Although we had seen that picture, can we discuss about the clinical part?
Yeah. Yeah. Are you able to see the clinical history there? As I said, he had inferior wall infarction in the past, and recent history is of the angina, exertional angina, NYHA class 2. And we did his echo shows ejection fraction of about 40% with the old inferior wall scar. And we did not do his TMT.
RC is also totally occluded. He has left main. You know, what is syntax score? What do you feel like that we should do PCI or CABG in this patient?
Always unending question.
Can I have a second why, please?
Second one, yeah. One is, these are the proximal lesions. It's a bifurcation, I agree. It can be, then we have to go by the syntax scoring system also. But we thought that we will treat it with PCI
the same way.
because the ARTS2 results are more or less clinically favorable.
Arts is also a large vessel that cannot be left alone.
Which one? Sorry, I didn't get you.
The problem is that my partner said he had an infarct before, and the right coronary is
anomalous in origin and total occlusion.
Yeah, there is a total occlusion of the right.
Echo shows the inferior wall thinning out.
Yeah, it adds, of course, it adds to the complexity of the case.
How is LV function like?
50%.
Not all branches are occluded.
And
40%.
Kidney function test is normal. Urea creatinine is normal.
Yeah, it's normal. It's normal.
It seems to be heavily calcified left main and bifurcation.
That is the beauty of this
so
case to
the
understand.
second plan is
because you have a
if
complex case going on in a very important live demonstration with Dr. Marie-Claude Morris here.
Yeah.
Yeah.
Dr. Morris, this is Dr. Sudhir Rathore here. As this patient has got severe calcification.
Yeah, hello.
Hello. There is severe calcification in the left main. Are you planning to use intravascular ultrasound to make your decision whether you're going to use a rotablation or you just go with a non-compliant balloon?
No, the lesion is too severe. I'm not sure we'll cross it with the... I will do IVUS after stenting. I will just test the lesion with a high-pressure balloon, a trio. If it's open well, that's okay. We'll go to stenting. If it doesn't open well, we will rotablate.
And before putting the left main stent into LAD, will you be dilating the circumflex ostium pre-dilatation, or will you do it after putting the stent?
No, I will do it after. Let's say, of course, there is two options. Or you do it before, or you do it after. But the problem of doing it before is that you get some dissection, and afterward, after stenting, sometimes wiring is difficult.
Yeah, I agree. This is a common...
So that's why. When it's not subtotal, let's say I prefer... you see, it's not easy to go in the circ.
Yeah, it's a very acute angle as well from the 90-degree angle from the left main. So let's have some discussion here from the moderators and the panelists. Dr. Rajani, what do you think should be pre-dilating the circumflex ostium before putting the stent, or should we do it the typical French way, that you should not dilate the side branch ostium, you should stent the main vessel because it can cause dissection at times, and it changes the angle of the carina as well and make it more difficult to do it?
No, definitely the circ is quite tight, and I would definitely dilate it. There's no doubt about that. I would.
He's asking, before putting a stent in LAD, would you like to dilate the circumflex ostium?
Yeah, that's what he said, yes.
You said yes?
Yes.
Before you treat the main LAD, LAD before that. Okay, just wanted to know, Dr. Makle, are you having the balloon support, intra-aortic balloon support? It's a very complex case, left main ostial with RC occluded.
Yeah, we do. Yeah.
Is it standby, or you have already used? Just in a standby?
No, it is not a standby. It's a standby.
Dr.
The
Morris,
the hemodynamics are good. The pressure is around 1.
Yes.
What guide wire you are using, just out of interest?
It's a BMW. You see, it was very easy to go in the LAD. It's more difficult to go in the circ, which is not surprising because of the angle. So I reshaped my my wire.
So it's very interesting, the question of using of intra-aortic balloon pump. I completely agree it's on standby, Because there have been some
Yeah.
studies recently which has shown that prophylactically putting a balloon pump and not putting balloon pump in a complex PCI with poor LV function does not have much influence on the outcome, but it should be on a standby and it should be utilized if there's any hemodynamic compromise.
If necessary, yeah, because we have an occluded right. Huh? So maybe we should try an hydrophilic wire because.
So which one do you
I
want?
think this is a right angle circumflex. So choice of guide wire, maybe some hydrophilic guide wire, some, like Filder FC. Madam, can you second choice of wire, maybe Filder FC?
Yes, Filder FC should be a good option, yeah. Because you see that I'm not able. I have a very marked angulation on my Y, but because of the lesion, it's completely flattened.
Another good wire which I've come across is Teomo,
Yeah,
the run through
DL3.
NS. It's a great wire actually.
And what about the Whisper?
What you required here, a slippery wire.
Whisper, any
circumflex.
hydrophilic wire will be
Filter
better.
group of wires may give a good.
Yeah, that's my plan. You see, because I am just in front, but just not entering.
Yeah.
And also, my
Just not entering the.
Dr. Gupta, ideally in these cases, we should first wire the more angulated circumflex and then go for LED. Because LED wire will definitely come in on the way when they are rotating the wire for circumflex, and it's not actually allowing the correct.
That means we can pull the LED and then try circumflex.
Let's do the LCX wiring and then do the LED wiring.
Not only that, once you have the complex lesion like this, we should always wire complex region first. Because while you're trying to
It's not a question of complex. The LED wire is coming on the way. The tip of this circ wire
I understand that.
is
not
not
only that.
going the way they like
Once
it.
you have angle like this, you're going to give torque, lot of torque there. Then the wire might intermingle at the side point. So you first wire the region which is very complex and angled.
Yeah, I think it's making it more complex because the lesion is very severe and the angle is 90 degrees, so you can have several things. I think changing the wire, changing the tip, maybe wiring the circumflex first and doing the LED if there's not much lumen there. It looks like the wire is entering into the circumflex, but when you
is he ready? Dr.
do
Rosalie,
any
is he
push,
ready?
it just collapses into the LED because it's so acutely angled, and it might be sometime in these cases difficult to wire this. Yeah, see, it seems
Can
to
we
be.
test, please?
Other option may be just you give a low pressure dilatation to LED, change the geometry of this bifurcation.
That we should do only once we lost all the options.
Yeah,
not at the first
maybe.
I
Yeah,
don't think
maybe
that
we'll
LED wire is
finish by
interfering
doing
here.
that,
It's
but
because-
honestly.
It's not LED wire which is interfering here. It's because of right angle which is interfering. The angle is very sharp.
Can we go AP caudal, please?
caudal.
Another thing which is
Can you
it looks
test, please?
calcific.
Yeah.
So whether the utility of a rotablator would be, I would really have a low threshold of doing a rotablator in this case.
I think so, yes, because that way the IVUS would have helped. Whether it looks like quite deep calcification, but it might be superficial. That's why the IVUS is helpful sometimes. It looks very heavily calcified, these vessels you put in the IVUS, but there is not much superficial calcification. In those cases, rota might not be of much use, but in this case, obviously, may be of use, but it all depends. Sometimes if you do a rotablation left main into LED, there will be debulking of the lesion, and it might be easier to wire the circumflex then. But that will be definitely the last option once you run out of all the.
Is you on GP2 band inhibitor also or just not?
Okay. We have not given him GP2B as at now. Okay. Shall we ask Dr. Rosalie to proceed and we do it comfortably?
Yeah,
Sorry?
Dr. Rosalie.
Because
will
this being a
want to show
complex
from another
patient
side.
left main.
Okay.
Dr.
Yeah, I think we will let you, Dr. Maurice, we'll let you work on this. You're doing an elegant job here. We'll move on to the other room and have some discussion in lab 2, and we'll come back to you very soon.
So,
Okay, no problem. I will reshape a little.
Can we go over to the next lab?
Hello.
Yeah, Dr. Rosli, how are you? This is Vivek Gupta.
Yes. Fine, thank you. Yes, Vivek. It's been some time since I've seen you. So I just would like to thank Suresh Sherimath for the kind invitation. So I've always wanted to come to Ruby Hall, and here I am now.
Okay,
so
good.
let's start off with the case. Dr. Sachin, and also we have got Sanle, and we're going to introduce this case before we show you the live.
Yeah. Good morning, I'm Sachin. He is 70-year-old gentleman, long-standing diabetic and hypertensive. History of CABG done in 1999. Recent onset of angina equivalent symptoms for last 10 days, and his angiogram showed long LED lesion, total occlusion of circumflex, and tight lesion in mid RCA. And in graft angio, Lima to LED is not functioning, and SVG graft 2, which is supplying diagonal OM and PD, shows a long lesion. We can run the
sequential graft.
Okay, perhaps you can have a look at the images. We have only captured for you the graph study, and this is the lesion that we're going to tackle today. And as you can see that this is a long graft lesion in the body of the SVG supplying the OM, and which also supplies the distal right. So this is a very important graph for him. What I've been asked is that I've been asked to showcase this and also to do the LED. And we have actually elected to do from the radial point.
Is this the only graft, or you had
radial artery, and this?
Is there a thrombus lying distally in the graft near the original branch also? In addition to lesions, after the lesion, do you
That's
get a
a
thrombus
possibility
there?
because we are going to actually cover that area.
There's thrombus there, isn't it? Some degenerative material, whatever it is.
There's possibility there.
But the branch arising from that point, which lesion matches that graft?
Yeah, I'm not sure what that branch is applying to.
If that's the branch by the anastomotic site.
But if at all, there's a small branch.
Which is site of
It's difficult
anastomosis?
to say because I think it is grafted onto the very distal OM.
Next.
Then what's that branch? If the graft is to distal
Let's go
OM.
to epicotal. Yeah, because if you see the anastomotic site is mainly end to site at the OM branch.
It's a venous graft.
But whatever it is, it's a small vessel. Yeah, it's a venous graft, it's a small vessel. We're going to tackle only the distal part, and I think that's the most important area that we're going to tackle, and hopefully it will be able to supply both the circ and also the right coronary artery.
So Dr. Rosli, this is Dr. Sudhir Rathore here.
Are there any? Yes.
So I think, this looks very interesting. It's got a long degenerated saphenous vein graft supplying a large coronary territory. What is the LV function like?
Yes.
What is the left ventricular function?
Normal LV function.
Okay, Dr. Rosli, how are you planning to treat this saphenous vein lesion? Just tell us.
Yeah, this is, I definitely would like to use a filter device in this case. We are going to pre-dilate, and we're going to put into stents, and I'm going to cover just at the point where the small branch is, right until the proximal to the severe stenosis.
In terms of adjunctive therapy, are you going to use GP2B3A up front, or just if needed?
No, I think we have just been comfortable with just heparin plus dual platelet therapy. And the data for, it's a bit controversial in terms of GP2B3A usage. So I don't routinely use in our SVG cases.
But you will use distal protection device?
Yes, definitely. Definitely. This is a 12-year-old graph, and it's a very ugly-looking graph, and definitely we will use a filter device.
Will it come to
Can I just show you what the filter device that has been requested from us?
Yeah.
This is an AmbuShield filter from Abbott.
Abbott. Neva 6. Neva 6. NAV 6 filter.
Yeah, NAV 6
filter. Yeah.
Okay. All right. I'll just show you how this this is supposed to be prepared. So this comes off at one with one tray, and you have this wire on this side, and also the extraction device, and the filter is on this side. So to prepare, what is important is that they've asked us to make sure that this point where the filter is, you've got to fill in water until the brim. Okay, once you have done that, then you're going to use a device, what do you call this? A syringe. And you're going to go inside here and flush the water out. And then on the opposite side, in the filter, you're going to do the same thing to try to get any bubbles out from the filter. Okay, and that's it. And when you flush, you can actually see the water coming out from the rapid exchange opening. All right, now since we have done that, we have actually pre-prepared that for you. We're going to take this wire out, and this is with a torque. You tighten it. Okay, and then you pull out, and you will then pull out the filter into the casing. All right, and you're going to pull it out until the gold marker reaches onto the black one. You probably can't see that well, but I can't tilt it because of I don't want air to be introduced in. All right, so once you have done that, then you take everything out, and then you're going to take everything as one unit.
So, Dr. Rosalie, does this filter device come in different size? Is there one size?
Yes. One is a smaller one. One is 2.5 to 4.8. The other one is 4 to 7. I think the 4 to 7 is used mainly for the carotids.
Okay.
What is this size? Can you just
so
repeat,
you can see
please?
that the filter is now inside.
This is 2.5 to 4.5
2.5 to 4.8. 4.8, yes. Yes.
This is a device from, I think, I don't know, it's Abbott from Abbott Vascular. This is just a digital protection filter device, I think. So what he has done, which we have not seen, is just in the inside the saline pool, he has retrieved the digital filter into the delivery catheter. Yeah. It's same as like Boston Scientific filter EZ or Spider device. I think it's from Abbott Vascular. It looks like something different.
The Spider device is definitely much different because it is over, once you get a wire in, you exchange over the wire. All right. Okay, and just come closer. Yeah. So we have a wire connected here, and this is a peel-away sheath, so we'll just push it. I think the most important thing is to ensure that there's no air.
Dr. Rosalie, the only concerning point here may be the lesion is very tight there, and it might be difficult to deliver the device distally. In that case, you might have to take a wire and dilate with a small balloon before delivering the device.
Yeah, we are fully aware of that. Small test, please, on me. Yeah. We are fully aware of that, and I'm hoping that we can try to do it without, but who knows? All right, so you can see, if you can see the from the fluoroscopy, please. Just concentrate on fluoroscopy.
Yes.
All right, good. Okay,
I think it will be a challenge to take the device distally with such a tight stenosis.
All right.
Just to understand, is it the only surviving graft, or you have LED device occluded?
Yeah, it is the only surviving graft.
Okay, so
this is the only
it's a further challenge to you.
Okay. Yes. Can I have REO, please? Well, the gut came out.
RAON.
035 wire ready.
Yeah, can we have O3 wire?
Use
Okay, I think we're going to have to try and see whether we
protection
can
device. What about the
engage this
proximal?
again.
Vivek, what about changing of if you have difficulty in crossing through a narrow lesion? What about using a proximal protection devices in this?
I think that there's not much. Of course, we do not have much of experience with proxies device, but you're right that such cases can be used. But I don't think there's much enough space there.
Landing zone seems to be educated proximally also.
Not only that, it's only surviving graft, then you cannot use proximal device at all.
In the graft, Cephalus vein.
It's only surviving graft.
That's what I'm saying, that it's a big challenge to use it. I would, just to have discussion, would you do it without using a protection device in such case? Of course, there is some degenerative material or maybe thrombus. Just for discussion, and when you do in your own lab, would you like to be a more simple and do a wire and just do balloon and come out?
It is almost all with protection device, but you can pre-dilate the lesion. Some other small balloon if you do.
But it's always preferable not to pre-dilate, because then the purpose of having a distal protection or one-in protection device is partially lost. You have
vis-a-vis that if your device is not crossing at all, then vis-a-vis pre-dilatation is definitely better, because with 1.5 mm balloon.
You do a wire, you do pre-dilate, put the protection device, then do stenting, and then.
In the real world scenario, how many percentage of us users is another question. See, ideally, it's supposed to be a class 1 indication, a distal protection device when you do an SVG intervention. But if you look at the data of Cath PCI registry, only 27% use that, a distal protection device. So the real world situation, it may be not that common.
No, a case like this, I don't think you can even think about doing it without a protection
No, I'm not
device.
saying that.
It's just simply too dangerous.
That is true. You're right. Just thinking of that. If you are not able to cross it, then of course you have to pre-dilate and then do a distal protection device, rather than not using it at all. Dr. Grant, I think your concern is very valid. But he's saying that only 10% Cath PCI data from India. You're talking from? 27% are only using it. Rest are not using it. That means we have to learn more and more, and experience required in all the cath labs which we are practicing in India, that we should use more. Of course, the cost is also sometimes a concern. You have additional of 30,000-40,000 rupees. How much is the cost, Sudhir? Any idea?
Around 50,000.
Around
50,000, yes.
I think saphenous vein graft, degenerated saphenous vein graft.
No question without protection device. You mean to say that?
If it is supplying a large vascular territory, obviously if it's a small graft, and you can do it without a distal protection sometime. I think this is one lesion one should try to use distal protection if possible.
One thing is more important, that your guiding should be very, very properly placed, because every time you are going to this guiding.
Which guide is it? Amplats? Which A2 or 1?
This is Amplaza, which is probably not aligned to the graft at all.
This is an Amplaz device, AL1.
It's AR1.
Stent?
Okay.
How long was the balloon? 15?
So we go to the other room, okay.
12, okay. So 20 will be okay.
Okay, Dr. Maurice, we are back to your lab now.
Okay. Go back.
Oh, go back?
Yeah.
How are you?
Do you want to
Go back.
Do you want to update us what you have done so far?
Yeah, fine. You saw this stage. We were next. We wired the LED, and we had a lot of difficulty in crossing the wire into the circumflex. We tried 3 different wires. First to BMW to start with, then Filder FC,
3.5.
And after that Whisper. None of them worked. So finally we dilated with the balloon to modify the lesion. And now over to Mari, how she had passed the wire. She will continue.
Yeah.
See, the same wire, as you can see, it has crossed beautifully, and Mari needs applaud for that.
Really well done, yeah.
It's to be congratulated. Yes, just wanted to know, suppose we dilate and then you further close down the circumflex, always a chance like that. But it's a good technique.
Yes, no.
But not in Mari's hand.
Okay.
No, I was frightened. Honestly, I prefer to secure the 2 branches before doing that. But it was really impossible. Really impossible. We tried for a long time.
Please.
So
3520.
Yeah, we
24. Biosensors.
We will put a biosensor flex.
Next run.
What is the balloon
Stand.
size when you dilate it?
3.5. It was, you see how tight was the lesion. It's
It was a sprinter, non-compliant.
Trio.
312. 312.
Which
Show the balloon.
opened well. You see, it opened very well without.
Balloon rakho to. 312. This was the balloon which was used. It was a 312 non-compliant from the Medtronics. And now we are going for the stent.
Now we are going for the stent.
3.524.
Yeah, 3.524, yeah.
Get the stent, please.
Can you be a little louder because you have to adjust your mic a little so that Dr. Makle, we can hear you a little better than what we are hearing now.
Okay,
So this
can you
was
hear
the
me now?
low pressure dilatation.
Okay. No, it was a high pressure.
High pressure.
Because we wanted to make the way and modify the lesion. Do you want to add to it?
No, you see the strange way that is taking the Y. It's really we needed the modification. Yeah, it's okay.
When balloon dilatation, did the balloon dilate fully? What was the balloon dilatation look like?
Yeah, it did.
Yes, completely.
Can you show?
Yeah.
Can you show the?
Yeah,
can you show
it dilated fully at 12 atmosphere.
By looking at the lesion,
Go
it
back.
looks there is the
Go
deep
back.
calcium, but it looks more like a thrombotic kind of a
Can you-
acute lesion at the
Yeah,
bifurcation.
Can you see the balloon?
Yes. Second thing is crossing angle
Can
of
you
LCX
see
was
the
not same
balloon
right angle.
dilated?
It has totally changed now.
Yeah, there is some wire bias. Actually, once they have modified the angle, it is coming, so it looks very severe at the ostium of the circumflex. But it might be that it's all thrombotic material. It does happen
Yes,
sometimes.
It is very important that you pre-dilate very
Yeah, but
absolutely
let's say
properly
I
before you put a
continue
stent
to
in the
prefer
calcified vessel.
not to pre.
So what is it? Can you explain the
I
technique
prefer
what you're
not
going
to
to use?
pre-dilate. I will stand from the ostium of the left main to the LAD test, please.
So the stent is 3.5 by 24 from Biometrics.
Oh, sorry. Yeah. It's biomatrix, yes.
Madam, O-ring is loose. That's the reason why it is.
Ah, okay. Sorry. Let's film like that. I want to be exactly at the ostium. Seems not too bad. Can we go epicranial? Epicranial, please.
Epicranial.
Is the best view to be sure that that we are well at the ostium.
Madam, nowadays, are
I
you
can prove
jailing
like
this
it.
filter FC wire when you are performing the bifurcation at Messi?
Yes, I'm gelling it. I have no problem with that.
And
Test.
there is no chances of wire fracture with these hydrophilic wires.
No. No.
As far as possible, we should avoid jailing
Maybe a
hydrophilic
little
wires.
more.
But you can go to some
Test.
pressure of 8 and then pull out, something like that.
The whole purpose is lost.
Okay.
The purpose is lost.
I think that's fine. Huh? Okay.
Do you agree the stent location?
You have to see a distal end of the stent also. It seems to be in some blocking.
Yeah.
I think in this case, obviously, you have to cover the ostium
Yes,
of the
then you can put
left
another
main.
stent
If you
there.
need another stent, you can put it down
Yeah.
further in the LAD. So I think
This is
looks like
Biometrics 324.
yeah, it looks like a good position.
3.5,
Yeah,
24.
no, but it's far enough. After that, we will be in the bifurcation.
3.5, 24.
Okay, we can go caudal again.
Epicaudal.
Because I don't want to be in the bifurcation.
Distal LAD diagonal bifurcation. That side point was important actually. See, exactly at that point.
Yeah, maybe we are a little
back
too.
little.
You would have
Yeah,
said- you
come
would have-
back
you
just
would
a
have taken
little.
slightly
yeah.
longer stunt. You really want to.
Test. Test. Okay, I think that
There is a
Okay,
disease
that's
there.
fine. huh?
Definite disease
Okay.
there.
Shall I go up?
Yeah.
I'm going up.
But how important is it to really cover from the ostium
yeah,
if
yeah,
it is not
yeah,
diseased?
yeah.
Of course, there's always a question because sometimes you can start from the body
Okay.
of the left main, if the ostium is all right.
What's the pressure? What's the
12,
pressure
yeah.
now?
Because to avoid any
12 is
edge
okay.
stenosis and
You
something like
deflate.
that.
12.
12.
12. Can you see that?
Yeah.
Yeah.
Okay, off. We will inflate more proximally. Yeah?
The hemodynamics is changing a little.
Was there some fall in blood pressure during the...
Yeah, it did
yeah,
up to 70. Now
yeah,
the pressure
now
is
it's
back.
improved. We are
110.
waiting. Okay. So we can reflate at higher pressure now to... you can go to 14, 16.
So what Dr. Morris is now doing is pulled the balloon back and doing the proximal high pressure inflation, what they call proximal optimization technique to enable to cross into the circumflex through the
let's say
stent strut.
Don't forget the hydrophilic wire is across the stent.
Can
you have to pull it out, of course.
Marker that.
You've gone to high pressure now. Still hydrophilic wire is across the stent.
Yeah, I think this could have been pulled out and then high pressure could have been given at that time.
No, at times we can use that as a marker when we want to recross across into the circumflex. Am I right?
Mm-hmm.
So this, Dr. Morris, I mean, we have been using the Cypher and Science and the Boston. So how do you feel about the biometrics, which is having better results in Leader's trial compared to...
I think the biometrics, that's the stent our choice now. Because of the result that you saw yesterday, short term is okay, but long term is really better. So can you? Okay. So we are. I think we are okay. On the LAD, and we'll have to rewire. I prefer to keep the Y in the LAD like that. So I need the.
Filter FC?
Oh, we can take the.
No, we'll get a new wire, no problem.
No, we can take the Y we had the.
BMW, or
not the
FC or
the Whisper, yeah.
Okay.
Dr. Morris.
Not necessary to take a new one.
Dr. Morris.
Yes.
What are you going to do now? Just tell us. Are you going to recross with the wire?
Yeah. Let's say. Yes, I will recross with the Y, and I take a third one. It's very important because let's say I want to secure. We are in a difficult situation with this patient with the right coronary occluded. So I don't want to move my LAD Y. Why? Because I'm sure 100% that it is in the stent, and so I will leave it like that, well secure in the LAD. At least I have one stent in the good position. And what I'm doing is going with a loop in the LAD to be sure that I'm not below strut, and then gently try to go in the circ.
And are you going to stent the circumflex in a T fashion or a reverse crush, mini reverse crush or T stenting?
I will first make a kissing balloon, and then see. Maybe it will be not necessary to put a second stent.
Okay, so you will do a kissing balloon and see whether the stent is required or not in the circumflex.
Yes, exactly. Yeah. Again, it's not easy to go in the circ. I'm not surprised.
Okay.
In this case, obviously, the circumflex ostial disease is extending more than 0.5 millimeter into the circumflex, so it's more likely
Dr. Vivek,
second stent will be needed.
So
we'll see.
Yeah, it's more likely that we will need
we are switching over to the second lab.
Okay.
Because
Dr. Rosli, where you have reached now? Dr. Rosli, can you hear us?
We have reached until the point that we are about to stent, but we'll show you what happened just now. Okay, let's go back.
Okay.
So this is the wire in trying. I really find that it takes a bit of use of getting the wire down because it is not as talkable as a normal wire, obviously. Next, so we crossed it, but in getting the filter down, it got caught, and this is at the part where the stenosis is. So the whole system actually came out. So what we did was we put in a BMW wire, and we pre-dilated with a 2.0 mm balloon. And that's the results after the pre-dilatation. So then we were able to pass in the filter fairly easily. So this is the wire. The filter is very free from the wire, which is, I think, an advantage in this case. So now you can see that the filter goes down fairly easily. All right.
That means you had to
it takes a bit of a while using this. Yes. And we are now at the point of wanting to put in a stent. So we are actually placing a stent in, and Sachin will take a picture and see whether we are there.
Now you have two wires. Your working wire is filter wire or second wire?
No, definitely it has to be a filter wire. And that is why the BMW wire has got a talker just in case you put it into the wrong wire. So you must be careful. I'm putting the wire there because I want it as a body wire before I take it out. So I think we got to go down a bit more.
It is very important you don't go second wire because you cannot retrieve the filter after that. You have to work on filter wire only.
Okay. Once more, shoot. All right, I think we are past. So I'm going to take out the BMW wire first. All right, okay, yours.
Which stent is it?
Okay, inflate.
Which stent are you using?
This is a Titan stent. I've been asked to use a Titan stent. This is a bioactive stent. Capture, please, honey.
Titan stent from Hexacat.
What's the pressure like now?
Yeah.
You used to go to low pressure in
and this is just 10 atmospheres. The blood pressure is 110 systolic, and we are just going about 10 atmospheres. Okay, down?
Yeah, down to?
Yes. All right. Okay. So that is the first stent. And I'm just going to place it here because we need to measure what is the second stent. That was a 3.0 by 22, right?
22.
All right, let's take a CD here. And Mac, please, for Mac 1. Mac 1? Yeah, Mac 1. All right, okay, go. All right, we can see that there's slow flow, eh? I think maybe there's something, a debris inside the filter. So I'm going to work a bit fast here. Can we inflate this, please? Yes. Can I have a 28? 2, 3. I'm just pre-dilating it because I want to make sure that my second step will go through. Okay? Down.
Yeah, I'm down.
Okay, can I have a 28, please?
We have a limited time. I think it's just like 3 minutes left only. So
okay.
Dr. Rosal, what is your usual choice of stents in SVG grafts? What is your regular choice of stents?
Is therefore.
No. I think with the data now saying that drug-eluting stent has got an advantage over bare metal stent, and this is a recent study which is primarily driven by a reduction in TLR, I tend to use a bare metal drug-eluting stent.
In case of no reflow in this situation, how do you decide filter need to be pulled back or need to do something else?
Okay, we have a bit of a problem here. I actually accidentally pulled back the other wire. Can we have the retrieval catheter?
The filter is slightly already back. Is it so?
Yeah, because instead of pulling the BMW, I pulled in the other stent.
Okay, we'll let you work on this, so and we'll move to the other lab briefly.
Just 1 minute. Just want to see how he takes the filter out now. He's already in the stent. Part of filter is already in the stent now.
Okay, Dr. Morris, we are back with you.
Okay, deflate, please. Yes, so you see that we are at the time of the kissing, with, we recross with your initial Y, which was the PT one. And now we just made a kissing 3-5 in the LED, 3-0 in the circ.
I think they're intertwining.
And I'm taking off the balloons now.
You use non-compliant balloon for the kissing?
Okay.
Dr. Morris?
Which balloon?
Yeah, it was a Sprinter NC 3.5. 3.5 by 15.
Yeah.
Show the balloon.
Which stent was chosen for the circumflex?
Yeah, I can't hear.
No, we just done the kissing balloon yet.
No,
and we
Okay, just done the balloon, okay.
Okay, let's see the result now.
Okay, so now we'll check. Let's see the result. Let's say, can we look another view? Seems not bad, huh? But
Spider?
Spider, yeah.
Even if you got stent-like result, will you leave without stent
No,
in
no,
a
no.
calcified vessel at all? Don't think
You have
so.
to put a stent, I think. You can't leave it, even with a good result.
Excuse me, please. Since the anatomy of the ear, anatomy of the left main is difficult, would it be appropriate to stent the left main into circumflex first and then take a stent into the LED? Because LED appears to be easier lesion to cross. Not now, I thought, before crossing the circumflex.
Just retrospective thought.
Yes.
I
Not a
think
bad
that
idea,
I will put a stent just before, because of the second lesion, you see just after the small marginal, where we had the difficulty to go. At the site, or maybe we can check by IVUS now. Huh?
Okay.
Huh? Look how it looks like.
Yeah, I think
Because,
that could be done.
If it's not
But it all depends from the very start, what is your strategy, whether you want to use one stent in the main vessel and then use side branch as a T-stenting, because in that case, you can easily do a Coulot technique here in this case, which will be ideal if you put a stent from the, and it depends on the size of the left main and circ as well, because the circ looks like a 2.5, 2.75 at the most vessel, and 3.5 is left main. So it will be difficult to put a stent in the circ into left main stem in this case. If they're equal size, you can try that and then put another stent into the LED. You usually do that in the crush technique if both branches, LED and circ are similar size.
I think the LED is at least 3 plus.
Yeah, the LED is 3.5. Huh?
So what is the plan now?
Yeah, 3.
We are doing IVUS.
We will do IVUS. If, yes, we will do IVUS in the circ, and in the, if it's okay in the circ, we will stop there, and if not, we will put a stent.
This is what I was asking for. Once you have stent-like result, in the calcified vessel like this, you have dilated to 3 millimeter balloon. Even if IVUS is fine, would you leave this without stenting?
There is little bit hedginess looks at the ostium
Yes,
or
yes.
proximal
Even distal part
circumflex.
of the circumflex, where the distal end of the balloon was there, that is not clean. No?
You have to
Just
put. I think
distal to branch.
You have to put a
to
stent.
one
I
branch.
Dr. Gupta?
Yes, sir.
You know, controlled dissection
Let's say
is the way by which
I
the balloon
see that
angioplasty works.
everybody wants me to put a stent, but let's say we have a large experience of single stent in left main, and it works very, very well.
No,
so
I was saying,
if the
you mean
result
to
is
say that
good
we
like
can
that,
leave it,
we will
I
do
think
it.
that
If not, we
if
will
you
put a
feel
stent.
that the lesion is hazy, then the controlled dissection is the way in
Ring
which
down.
angioplasty used
You
to
can
work
do
in
it.
the past.
Ah.
My point is, currently the criteria
Yeah.
that in most of the cases,
wait,
one stent technology
Okay, you can
is
do the ring
bringing
down
out
now.
superior results over the long term as compared to two-stent technology. The guidelines are clear.
But
Either A, if there is
No,
a
you
threatened
bring it up,
closure,
bring it up.
or there
Bring
is
it
a
up.
It's okay.
less than TIMI3 flow.
Can-
I think
can
you
you
observe
do
this
the ring
case,
down?
do the IVUS, watch for 15 minutes, and if everything is okay, in my lab, I would do even FFR and find out that if FFR is 80, 85 or so, maybe I'm happy with one stent.
No, but in this
Here is the fear of sudden
down is
threatened
done?
closure.
Okay.
How you justify this case?
Majority of
Okay.
the balloon
So we
dissected
are,
lesions
Mid
if
or
they
distal
close
artery,
down,
okay.
majority of the balloon dissected lesions close down.
Do you see the
they close
IVUS?
down in the cath lab in 15
Please show the
I
IVUS.
think I agree with Dr.
We
Mehta
are,
in this case.
we are in the...
Well, that is okay for LED D1 and
You can-
CERC for OM1, but it's such a where there's a big
you
area
there
involved.
the IVUS?
Yeah.
I mean, it's a question of debate, but of course.
Okay. Are you able to?
Yeah, we can see the
Okay,
IVUS.
sorry to
just-
interrupt you.
Yeah,
Are you
yeah.
able to see the IVUS on the screen?
Yes.
Yeah.
Just tell us
so
what you
we
can
are
see.
in the CERC. We are in the CERC.
Start recording.
Dr. Mehta, the very
I'm
complex
putting,
lesion like this.
Can we see the IVUS, please? Can we see the IVUS image? Yes. So this is a pullback of IVUS from...
Do you have it?
it looks good.
Okay. Oh, sorry, it jumped. And this is the left main. I'll try to go, this is the ostium of the CERC. And this is the proximal CERC. So can you measure?
Yeah. Stop.
Yeah. And this is the left main, which is ovale, is normal. We made a kissing with two balloons.
I think what Dr. Mehta is saying is if you do, if you look, if the end result, end of the procedure is TIMI 3 flow and the residual stenosis in the circumflex ostium is less than 50%, either on IVUS or angiographically, and there's no immediate closure, obviously waiting few minutes, and I think that will be a good result without putting another stent.
Okay.
As the other studies have shown, putting another
Measured,
stent might cause more stent thrombosis and things like that. There's no threatening closure here. So I would agree with that, to leave it.
Yeah, I think this
No, if
simpler
there is a
thing to
need
do.
of a second stent, we will put it. But let's say...
That makes the procedure more simple, of course.
For the small vessels, it's good, but it's a important vessel,
So
proximal
the,
circumflex.
such a complex
osteal
for
lesion.
O.
Circumflex artery
Need to be
lesion,
studied.
when you see before dilatation and stenting, it was very, very nasty lesion, large vessel.
Area is
I
about
will not be
8.7
comfortable living
maximum.
without putting a
Minimum
stent
area
in
is
circumflex. It has to be stented because there is
Minimum is
definite
3.
possibility of late closure.
Okay,
Anytime
so
it
I
can
can
happen,
put a
not in the
stent
cath
there.
lab necessarily.
Okay.
Even in the hospital after a few hours.
Dr. Mehta,
So we have only few minutes left, I think. How much time we have left with? 15 minutes. Okay.
Yeah.
I just want
Yeah.
to know what was the
318.
size of the balloon in the circumflex and what was...
3 millimeters.
I think
yeah, I know,
It's a
but
trio.
and
It
what
was a
balloon
trio.
was it and what pressures? The kissing?
Non-compliant.
So the balloon.
Madam, there is a question from the audience.
It was a Sprinter.
You are doing maximum
NC
bifurcation.
from Medtronics.
Madam Morris, can you listening us?
It was.
Yes?
You are doing maximum bifurcation
Yes,
and
I
Tharil
hear
FF is
you
doing
very
maximum.
well.
How you are deciding the sizing of balloon for bifurcation, especially left man? Which size and what balloon?
planning for
we
stenting
take...
now?
Bifurcation.
This is
no,
a balloon.
trio.
Now we take a stand now.
The stent. You have no shorter?
313 next is 14.
Yeah, 13 or 14, no.
14, we have got a 14?
13, no.
No.
The size before, 314.
On IVUS also, it doesn't
This
look,
one
the
is too
area
long.
was less than 4 millimeters square, so putting another stent in will be a right option here.
Yeah, exactly. So that's why we put another stent.
No, 314 is not available.
Okay, so
318.
let's take this one. And we will prepare the balloon 3.5 on the LED.
Yeah. Sister, give me the 3.5 balloon.
So for the answer to the question from the audience
it
was,
on-
Dr. Morris has used 3.0 millimeter balloon in the circumflex and 3.5 in the LAD. And you usually advise when you
Yes.
do a kissing balloon, you
Yeah.
match the vessel size and do a high pressure inflation. And what it does in the proximal
Yeah.
part of the bifurcation, it increases the area by 2/3. So 3.5 and 3 balloon non-compliant will give you about 4.5 in the left main stem.
Yeah. Yeah, exactly.
Her reason,
So,
I think, after doing the IVUS,
I will put,
doing the IVUS, the vessel
after
size.
doing the IVUS, we decided,
Let us speak here.
Yeah, go on.
Dr. Morris, please go ahead.
we are
Dr.
okay.
Morris?
Can we prepare the stand there?
Dr.
Yes.
Morris, why did you decide to put the stent after the IVUS?
because the lumen was a little less than 4 millimeters square on the ostium of the circ, which I think was not enough. No visible dissection, but let's say.
I think the more reason in this case is the ostium looks much better, but the distal to the ostium there is several
distal to branches.
And it's a long area, so I think if it is only ostium,
exactly.
then you can leave it sometime. But here there is further disease down the ostium.
Yeah, but there was also distal disease, yes. So what I'm doing is
can we briefly go back to another lab, please, Dr. Rosley's lab?
Okay.
Let her finish the stent.
Yeah, sure.
What strategy? Sure. I mean, is it a T? Okay, let you go on to Rosley.
Yeah, Dr. Rosley, can you tell us
okay.
what you have done? We are running short of time now.
Just want to know what to do with the filter at that given time.
We had a lot of a lot of challenges here. Can we go through? So as you see just now, the guide, the wire actually came out, and the filter actually went a bit more forward. And we wanted to try and see whether we can push in the retrieval catheter, and with that, push it down, the filter down. So we managed to do that with the body wire. Next. But unfortunately, we cannot retrieve, when I pull back the retrieval catheter, the filter will not open up. So we decided and say, look, let's not use the filter anymore.
But how can you push the filter down again?
And since we don't have any other filter,
see, that will push.
We can't. We tried to. We got the filter down, but we cannot open it.
So you push the filter
so
back.
We decided to abandon the filter. Yes, we did. We pushed it down, but we were not able to, to deploy it again. Okay, we're going to have to understand in this.
So you have not used the second filter then?
Okay, deploy now. No, we don't have any other filter anyway. 10, 12.
Still, proximal part of the lesion is still there.
So we will have to make use.
Stent is shorter.
Okay, down. Okay, can we have a short stent, please? Another one.
You have to be very careful.
So that was a 28. I think we didn't cover the proximal.
The purpose is not completely fulfilled.
All right.
Instead of using multiple stent, why didn't you use the long stent itself? Because using 3 stent overlapping edges, that will be.
Yeah. Actually, we want in the beginning we said that it's going to be 28. So therefore, the 28 has already been opened. And I think after all that, that drama. So now we know that we don't cover it. So I would have actually used a longer stent if in the beginning it was thought to be longer. But I thought it was going to cover with just a 28.
13.
One small question again. Why did you try pushing filter down? Is it advisable to push the filter again?
No, sometimes what you can do is with the retrieval device, especially with the Boston, once you get it down, you can try to deploy the stent once again, deploy the filter again.
But better a mug, you have retained that filter that we lost just till when
so
you push the filter down.
Yeah, I mean, hopefully the filter, when we close it, it will capture whatever debris that is inside, and therefore it should not release open. Of course, there's going to be some possibility in that end.
So finally, are you going to put...
So I couldn't do it in this case.
Are you going to put another stent or what to do?
Yes, we're going to put a third stent. But as you can see, even with stenting, if you choose it very well, you don't go very high pressure, you don't be too aggressive in terms of the stenting size, you could actually get away without, without a higher risk of debris.
Okay, can we go back to Dr. Morris's lab and we will come back to you, Dr. Rosley, briefly, just before you finish off. Dr. Morris, we are back with you now. Please tell us what you have done.
Okay.
Just show us the stent position before dilatation.
So we have finally...
Go back. Back. Stop. Next.
Okay, so...
Yeah.
So this is what we did. We position carefully our stent to be, let's say modified T or mini crush, to have a little bit of the stent in the lumen. And let's say we were happy with this. We did stent boost to be sure that the positioning was okay. And you see that we are 1 millimeter in the main stent. So that's what we did. And then we make a kiss. The balloon in the LED was ready. We implant first the stent, then we pull both balloons and make a kissing at 14 atmosphere. And here we are to show you ready to show you the final result. I hope it will be the final.
After mini crush, you crossed again LCX?
A very good result, but...
Thank you.
We can go to... yeah, I think the result is good. It's a 3035. Okay, inject, please. Okay. Can we zoom on the left main? I think that...
Now we are giving 2B3 inhibitor.
I think that we can be happy with that result. There is no geographical miss. We did not miss the ostium. Personally, I'm happy with this, and I think if you are happy too, my friend.
Yeah, that's a great result, Dr. Morris. We would like to congratulate you for doing such a complex case. Thank you. Can we go back to Dr. Rosley's lab now, please?
Yeah. Okay.
Yeah, we are with you, Dr. Rosley.
We have got some interesting things to show you. So we are putting the last stent. That's another Titan 3.0 by 13. Next. That's about 12 atmospheres, and that's the results after. So you can see the flow is very good. Okay, next. And another view. So that supplies a right coronary artery. Next. This is the epicaudal view. So once again, so we didn't have any, looks good flow, TMP flow. But Sachin, would you like to show the filter?
Dr. Rosley, you perform this case with protection device.
You can actually...
without protection device.
In the distal, but not...
Yes, we used half the case.
Whether you use GP2B3 receptor inhibitors or not?
So you can see there's a lot of debris there. No, we didn't use it. I think that you can see that there's lots of debris onto the, in the filter.
So do you find something there?
It's full of debris. Seems to be full of debris.
Yes, lots of it.
Dr. Rosley?
So we're quite fortunate because, yeah.
What was the inflation pressure for the stents? How high pressure did
Only
you go
10
up?
to 12 atmospheres.
10 to 12.
And that's it.
How much?
10 to 12. 10 to 12.
Do you want to comment on the high pressure inflation post-saphenous vein graft or low pressure versus low pressure inflation?
No. No, I would tend to go low pressure, maybe a bit longer if the patient can hold on. But in this case, we did not go very high pressure. 10 to 12 atmospheres is fine.
Yeah, that's a great result, Dr. Rosley.
Secondly, is that we were not very aggressive. Thank you very much. We were not very aggressive with
so
the
much,
size, so we didn't go to 3.5. Right, thank you.
Okay, it was a great discussion for both bifurcation as well as left vein for saphenous vein with distal protection device or without. I think it was a very fruitful two cases which we had.
One edge of the stent is inside, then you crush it.
I think we've any other suggestion from the audience or anything else? Dr. Mehta, finally, Dr. Ashwin Mehta.
Any other question from the audience before we wrap up this session? I think we should just wrap up this session now. It's a very good session. We'd like to thank all the panelists for contributing to the session, and we'll move on to the next session now.